Thank you for that introduction. Good afternoon, everyone. Welcome to the final day of the Iowa State Conference on Race and Ethnicity. We are Durga Sritharan and Bennett O'Hare, and we will be presenting on generational trauma's effect on Indigenous communities reliant on Western healthcare. Before we begin, we would like to extend our gratitude towards the ISCORE and NCORE ISCORE project committees for making this experience possible, and a special thank you to Dr. Ruxandra Marcoux and Dr. Erin Peterson for serving as our professional mentors throughout this project experience.
We would like to begin this event with a land acknowledgement. Iowa State University is located on the ancestral lands and territory of the Bakose, or Iowa Nation. The United States obtained the land from the Meskwaki and Sauk nations in the Treaty of 1842. We wish to recognize our obligations to this land and the people who take care of it, as well as the 17,000 Native people who live in Iowa today.
So here's our agenda for today's presentation. First, we would like to go more in depth with some introductions of ourselves and the inspiration behind this presentation. Next, we will discuss generational trauma and health disparities within Indigenous communities. After that, we will host a group activity, followed by a call to action and a brief conclusion. After viewing this presentation, you are more than welcome to ask questions through the Q&A session or via email.
As for our learning outcomes, attendees will learn how generational trauma highlighting racism and prejudice within Indigenous communities serves as a barrier for patient-physician relationships. Attendees will also learn about elements contributing to various health disparities with Indigenous communities.
So, like I said earlier, my name is Durga Sritharan, and I am a senior majoring in biology and minoring in psychology. This is my third year presenting at ISCORE and my first year as an NCORE ISCORE scholar. Outside of this program, I am a peer mentor for the George Washington Carver Academy and Biology Education Success Teams Learning Community. I volunteer at Mary Greeley Medical Center and Youth and Shelter Services, and I'm involved in the ISU Neurophysiology Lab. I'm currently attending the University of Georgia for National Student Exchange this semester as well.
Hello, my name is Bennett O'Hare, and I'm a junior majoring in biology. This is my first year presenting at ISCORE, and I'm also a first-year NCORE ISCORE scholar. Outside of this program, I'm involved on the executive team of Dance Marathon at Iowa State, as well as involved in the pre-med club. Outside of Iowa State, I work at Mary Greeley and volunteer at Food at First. As we both mentioned, we are biology majors on the pre-med track. Even though we are on this track, we have not been aware of these prevalent issues that are concerning. And this inspired us to take this research and bring this to the forefront.
So before we get into the main content of our presentation, we would like to know about your current understanding of generational trauma, health disparities, and how the two correlate. With the people around you, we would like for you to discuss how you would describe the terms generational trauma, health disparities, and what it may mean when the two terms are used together. Afterwards, if you could get out your mobile devices, we will share a link and a code for you to share your answers. So now, if I could get your attention, we will be going to menti.com. So that's menti.com. Um, and then it will prompt you to insert a code. So the code is 68376226. And the first question is, what is generational trauma? And just kind of put into short phrases what you guys talked about. So some of the things that we've been able to see so far is mistreatment and resulting trauma that lasts from generation to generation. When an initial trauma is passed along in some way to future generations, continued effects of marginalization, oppression, colonization on families, intergenerational physiological and psychological changes due to disrupting event or series of events. All right, so all these are really good. We will move on to the next one. So kind of the same thing here, just describe what you guys kind of talked about when thinking of different health disparities. So what are different words or phrases that come to mind when you think of health disparities? Okay, so as these start to pop up, we can see people are saying not equal access to healthcare, differences in health experiences and outcomes, white doctors who don't know how to treat brown bodies, lack of access to healthcare, or healthcare providers who are knowledgeable in what you need, inequality in accessing healthcare and treatment. So all of these are really good ideas.
Now that we've discussed what generational trauma is and health disparities, I would like you guys to discuss with your people around you how you think they correlate and how they could affect one another, and then have one or two of you guys share what your guys' thoughts on that are. All right, do we have any volunteers that would like to give us their thoughts on how they correlate? Would anyone like to give us their thoughts on how they thought it would correlate with each other?
All right, so for the people on Zoom, they kind of discussed the correlation as to how generational trauma can definitely affect the quality of healthcare and how it can lead to different trust issues and how dangerous it can be if these issues are not fixed.
Now that we have explored different perspectives on the meanings of the two aforementioned terms, we are going to take a deeper look into both terms and their correlation to each other and the Indigenous community. We are going to start with generational trauma. The definition of generational trauma is trauma passed down directly from those experiencing an incident to subsequent generations.
Now we will view a brief video that goes more in depth regarding the term generational trauma.
Lots of things get passed down through generations. Stories, heirlooms, genetic traits. A new field of study is suggesting that even trauma may be passed down through the generations. Let's dive in. First, what is generational trauma? Well, it's exactly what it sounds like. Trauma that isn't just experienced by one person, but extends from one generation to the next. Here's child-adolescent psychiatrist Gayani De Silva to help explain.
If you have somebody in your family history who has suffered some sort of trauma, let's say racism or slavery or being the survivor of the Holocaust, that experience in your ancestors does get transmitted from one generation down to the next generation, to the next, and to the next, and to the next.
The concept was first recognized in 1966 by Canadian psychiatrist Vivian M. Rakoff. Rakoff and colleagues recorded high rates of psychological distress in the children of Holocaust survivors. A 1988 study found similar results with the grandchildren of Holocaust survivors. Since then, their descendants have been the most widely studied group. But in theory, any type of extreme, prolonged stress could have adverse psychological effects on children and or grandchildren. How do health experts spot the signs of generational trauma? There are actually quite a few ways it could show up.
For when you're sitting with a patient, you would look for their specific signs of trauma. So you would look for mood issues or anxiety issues. Those are the primary big symptoms that people typically present with. And then you want to do kind of an investigation of why they feel depressed or they feel anxious or they're having some mood issues. And then you start to ask, why do you think you might be so depressed? Why do you think you might be so anxious? When did that start? Has it always been there? And so when people say, yeah, I feel like I've always been anxious, I've always been kind of depressed, and my mood has always been sort of irritable ever since I was a little child, then the lights got to go off in your brain. You got to think, oh, I wonder what happened before they were even born. I wonder what happened with their parents. Did any of your parents feel depressed or anxious? And then we'd ask about that. And then we'd say, oh, how come they felt depressed or anxious? Were they ever victims of trauma?
Even with all those symptoms for health experts to consider, there's no specific diagnosis for generational trauma, according to the DSM-5, which is the standard classification of mental disorders used by mental health professionals. But the phenomena of intergenerational trauma is well accepted.
It's a learned thing that your brain actually learns, and then the DNA actually learns it and then turns on certain DNA sequences versus other sequences, and it affects brain development. It affects how you learn how to regulate your mood. It affects how your limbic system, which is the part of your brain that is involved with managing emotions, how that develops. And it also has implications on how you react to stress.
Unfortunately, there are no easy answers, but generational trauma can be resolved if a holistic, intense intervention is put in place. This often involves individual therapy, though group and family therapy is another option.
Depending on how severe their symptoms are. So if they're anxious all the time, they're having panic attacks and they can't seem to function as they would like to function in their daily life, we might try medication. So something like a selective serotonin reuptake inhibitor. These medicines are like Prozac, Lexapro, Celexa, Zoloft. Those are kind of the common ones. And we would also highly recommend and want our patients to be in psychotherapy, because psychotherapy is going to help you understand where that anxiety is coming from, where that trauma is coming from, and help you put it in a way in your brain so that you can deal with it, you can handle it, and so it doesn't manifest in symptoms.
If you think you may be experiencing generational trauma, seek help from a behavioral health provider. Lots of things get passed.
After getting a better grasp on what generational trauma is, we're going to correlate it directly to the Indigenous community and the effects generational trauma has on the Indigenous community. Mistrust is a major barrier when it comes to healthcare system. This mistrust can be formed by many different things. According to Canales et al., it often stems from a lack of cultural awareness on the part of the physician and other healthcare professionals. This situation is often worsened by patients and family members' limited ability to negotiate clinical healthcare systems by a lack of detailed clinical information. Another major factor when it comes to mistrust is the quality of healthcare, and that determines on whether or not patients will attend checkups. And then there was a study done in Vermont of Native American women in Vermont, and it actually included interviews regarding individual experiences, and we'll get into a specific interview that was important on the next slide. So this is the story of Jessie, and this was from the interview that was done in the study before. So Jessie had been experiencing night sweats, fever, loss of weight, and had a lump under her arm when she decided to go see her primary care physician. The primary care physician kind of brushed it off and said it was a cyst and prescribed antibiotics. She then her symptoms got better after a while, but then they returned. And so she went back to her primary care physician, and the primary care physician, again, prescribed antibiotics. After this was going on for 3 months, she decided to get a second opinion, and she was diagnosed with cancer. And that cyst would have been able to be surgically removed had this diagnosis been earlier. However, she wasn't able to remove it completely, so she had to do chemo. She said this resulted in families' mistrust of the healthcare system within herself and her friend's family, as they had dealt with a misdiagnosis with that community. This story is not uncommon when it comes to the Indigenous community. For example, cancer mortality rates increased 5% from 1996 to 2001 compared to 1990 to 1995. In the general population, during that same period, cancer decreased 6%. And this is due to most Northeastern Native communities not having access to resources such as cancer education or outreach programs.
So as Bennett just highlighted, generational trauma has a great correlation with health disparities within Indigenous communities. According to the CDC, health disparities are preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups and communities.
There was an article done in the Seattle newspaper highlighting the Indigenous healthcare, mainly after COVID, but it says that the US government signed a treaty in 1982 to provide health services to the Indigenous communities. And during that treaty, the health services was the Indian Health Services, and only $4,078 is allocated per person, whereas opposed to the general population normally has one of the 3 major healthcare services, and that's Medicare, which allocates $13,185 per person. Veterans Health Administration allocates $10,692 per person, and Medicaid allocates $8,190 per person. So as they did provide healthcare, this healthcare wasn't up to the standard of the healthcare that the general population around the rest of the United States had. So this has led to the worst standing for most health conditions. This is just a few of the health conditions. As you can see in this chart, there's diabetes, stroke, heart attack, coronary heart disease, and depression. But among that, Indigenous communities have the lowest life expectancy, highest infant mortality rate, highest suicide rate, and highest risk of asthma. And more recently, we decided to look at coronavirus statistics. And according to the CDC, the Indigenous community was hit the hardest. They were 1.7 times more likely to get COVID than the general population, 3.5 times more likely to be hospitalized from COVID, and 2.4 times more likely to pass away due to COVID.
Another prevalent healthcare disparity that shows eye-opening standings for Indigenous communities is the opioid epidemic. The opioid crisis has been an ongoing and prevalent issue for years and even decades. The opioid epidemic is the phrase used to describe the overuse, misuse, or abuse and overdose deaths attributed either in part or in whole to the class of opioids. The National Institute on Drug Abuse states that pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers, and healthcare providers began to prescribe them at greater rates. This subsequently led to widespread diversion and misuse of the medications before it became clear that the medications could indeed be highly addictive. Indigenous communities are correlated with the greatest opioid usage and drug trafficking rates. This has led to these communities having the highest prescription opioid death rates. Major contributing factors that affect these statistics include the lack of opioid prevention methods in communities and funding for such programs. Due to this crisis, many physicians' first instinct is to assume that their patients' complaints are automatically tied to substance abuse. For example, in 2020, Joyce Echaquan, an Atikamekw woman, died due to pulmonary edema in Quebec, Canada. Pulmonary edema is a condition that is caused by excess fluid in the lungs. The coroner that investigated her death, Jehan Kamel, concluded that racism and prejudice that Echaquan had faced factored into her death. On September 28th of 2020, Echaquan had documented video footage of healthcare staff making racist comments towards her, which led to an outrage and number of protests after her death. Kamel had stated that the medical staff assumed that Echaquan had suffered from withdrawal, altering their path to provide medical care. However, there was no actual evidence to support the claim that she was addicted to drugs. She did have diabetes and cardiomyopathy, or heart muscle disease, which should have heavily influenced the path of care, as she had complained about having heart palpitations while she was at the hospital. Kamel concludes that her death could have been prevented if she had been treated with proper care. Kamel is currently looking into calling out province officials in Canada to recognize and eliminate systemic racism, especially towards the Indigenous community.
Okay, now after learning about generational trauma and health disparities, we're gonna move into a group activity. In this group activity, you can work with the people next to you, and you're gonna pitch a program initiative that would help alleviate health disparities for Indigenous communities. And for this, we would like you guys to come up with a program name. You don't have to come up with a program name that's catchy or anything. Who does it serve? And then the challenges or barriers that it targets. All right, we'll give you a couple more minutes to wrap up your guys' conversation. All right, do we have anyone that would like to share what their group discussed? Would anyone like to share? Would any of you guys would like to share?
Okay, so we came up with, we thought something that would either, like, what is it, a checklist or something that would make them question their assumptions. So, like, maybe if you have someone, like the computer has, okay, well, this person is an Indigenous background, so, you know, are you sure you're not, you know, like, are you sure that they meet these symptoms? You know, so like in the case of the person of Joyce, how they assumed that she was just addicted, well, you know, does she do this? No. Does she do this? No. Well, then it's not an addiction issue. It's something else. I think a lot of times doctors have to rely on their memory and have to, you know, just, and they get so tired because they're overworked and they see so many people, and it's just easier to assume, your brain just wants to assume that it's the same thing you've seen before. Just something that kind of interrupts them, or to make them question their assumptions. That's what we were thinking would be helpful.
You would like to go?
I don't know if we were thinking on the right lines or not, but we thought maybe going into Indigenous communities and having someone promote within for scholarships and education and helping other Native Americans maybe pursue a career in medical fields, so that they could go back and that trust would be there for their communities. So
we were talking about how the health service, the Indian Health Service, pays, like, will take doctors and pay their student loans off as like an initiative to have you come and, you know, work on the reservation, but that really like brings in doctors who have that motivator, who aren't like dedicated, aren't invested in the community. So I think rather than giving an initiative to help bring strangers in, rather I think it would be more productive to encourage education and help people on the reservations be able to, what am I trying to say? Pursue education. People who are invested in their communities, you know, are going to be much better able to connect to their communities and serve their communities than, you know, the white savior coming in, you know?
All right, well, thank you all for engaging in discussion and sharing your input.
So one of our major parts of the ISCORE project was to connect this back to Iowa State. And this took us a while because outside of just the sheer students at Iowa State, which isn't a very high population, there's really not much being said or taught about this situation that's going on. And we felt as if that was the issue within itself, was that we're both pre-med students and we had not heard of this issue. Like, we had to do separate research to learn about this issue. And we felt that was the issue within itself, so that's what we kind of addressed when we thought of our initiative.
Yeah, and to point out, one of Iowa State's principles of community is freedom of discrimination, and we cannot actually strive to make progress for equality at this institution if there's a lack of trust, not only within the healthcare system, but also at the institution as a whole. And so it's important to note that everyone has biases, but we need to be proactive and challenge those biases to make this institution a more inclusive and safe environment for students, faculty, and staff. And so that is why we have decided to create a hypothetical initiative of our own that's applicable for students, faculty, and staff, entitled the Health Disparities Certification Series. Within this initiative, we have created 4 different stages of seminars for this series. So the first level of the Health Disparities Certification Series is HD 101. So this is Introduction to Health Disparities, and this seminar will provide a basic foundation for participants to understand the overarching concept of health disparities and the importance of acknowledging them. The second level of the Health Disparities Certification Series is HD 201 to 204. And so these 4 seminars highlight health disparities among different racial minorities. And there are seminars that will focus on Indigenous, African American, Asian Pacific Islander, and Latinx communities in no particular order. And then these 4 seminars as a whole can also showcase and serve as an introduction to the lens of health disparities among multiracial communities. The third level of the Health Disparities Certification Series is HD 301 and 302. And these 2 seminars focus on analyzing health disparities of the LGBTQIA+ community and people with disabilities. These 2 major minority groups stem beyond racial and ethnic minorities, with people with disabilities being the largest minority group in the world. The final level of the Health Disparities Certification Series is HD 401, and this last seminar is used to analyze health disparities through the lens of intersectionality. And so various intersections of identities such as race, gender, age, etc., can contribute to the quality of healthcare that patients receive.
So overall, analyzing generational trauma and health disparities within Indigenous communities has opened a wide lens of many prevalent issues within the Western healthcare system. Our experience as INCORE ISCORE scholars and pre-med students has opened a door of opportunities to continue research and education and inspire future generations of community members and healthcare professionals.
So thank you so much for taking time out of your busy schedules to attend our session. As we mentioned earlier, if you have any questions, please feel free to reach out via email or talk to us in person. Additionally, we would greatly appreciate your feedback. So if you could fill out the survey at the end of this session, that would be wonderful. But once again, thank you so much, and we hope you enjoy the rest of ISCORE 2022.
Are there any questions? Yeah. So one thing I did forget to mention about this was we were looking at other universities and if they've had initiatives like this, and the only thing we found was at the University of Florida, you can actually minor in health disparities. So they offer an incomplete 15-credit minor, and that was the only university that we found that offered such courses. So we thought it would be cool if we could adapt not like a full minor, but a seminar series at Iowa State that could help, you know, go into depth about not just Indigenous communities, but other marginalized communities.
Yeah, that's a good question. We would ideally reach out to healthcare professionals from different areas of medicine and in healthcare administration to see what their biases have been and situations and experiences that they've seen in the past, and kind of have them reflect on what's been happening, what needs to change, and what they would like to see in the future. Yeah. So, what like ideally would happen is, like when we include the different healthcare professionals and administrators, we would like to reach out to people of the different backgrounds to kind of explain what they've experienced in the past and how to move forward with that. Mm-hmm. Mm-hmm.
Yeah, so when we were going over this initiative, we thought that when we pitch this, we should do the like pitch what something that is attainable sooner rather than later. So preferably attainable would be to have an actual minor and then have courses where people from that background could come in and teach and then offer their programs to the students. So if the students were interested in the healthcare field and they were Indigenous, they could go into that field because the members of that community came and talked to them and presented them with different opportunities. But this was kind of, when we were kind of talking about this, is that something that we could attain more like recent, like soon. And then, but this is like just the first step. I felt like Iowa State can make many steps after this, whether it goes from becoming an actual minor or anything along that. But this is just like the first step. We thought, start at the base because there isn't really a base there. So we have to start somewhere, and this was the idea that we had to start. Yeah, I think so. So when we talked about this, we both were pretty adamant that we're pre-med students, but we don't ever get taught the hard stuff that the healthcare system has to deal with in situations like this. So we thought that it would be a good program for not only people in the healthcare and staff, but also for pre-med students to attend, so then they go into the like med school or pre-PA or any sort of health field already with the base knowledge, so that they can be aware of how they are going to function when they're a professional in that field.